In lessons 6 through 8, we focused on diseases and conditions that cause restrictive lung dysfunction. In the next 2 lessons, we will concentrate on obstructive lung diseases, or OLDs, their tested diagnosis conditions, management or treatment of these diseases, and prevention where applicable. As we know, obstructive diseases affect the airways and produce obstruction to expiratory flow. This obstruction may be related to retained secretions, mucosal inflammation in the airways, bronchial constriction, weakening of the airway support structure, or alveolar destruction and surfactant deficiencies. Chronic obstructive diseases such as emphysema and chronic bronchitis are currently the 3rd most deadly diseases, right behind cardiovascular disease and all cancers combined. Other obstructive diseases include asthma, cystic fibrosis, bronchiectasis, and bronchopulmonary dysplasia. Patients may present with signs of hyperinflation such as elevated shoulders, horizontal ribs, barrel chests, and low flattened diaphragms on chest X-ray. This slide shows a chest X-ray of hyperinflation from the AP and lateral views. The lungs will appear radiolucent even on exhalation X-rays, and diaphragms will lose their rounded appearance and appear flatter. The A to P diameter is also showing the barrel shape. Abnormalities in gas exchange can be seen with ABG showing low PaO2s and PaCO2 levels that are decreased in early obstructive disease due to tachypnea and elevated in chronic disease or impending respiratory failure. Dyspnea on exertion is common and may produce a high anxiety level leading to more dyspnea. Secretion production and cough may further impair functional activities. Common postures of patients with COPD may show forward-leaning and tripoding, which is a compensatory mechanism to help with exhalation. Pulmonary function testing is an important diagnostic tool to quantify the degree of airway obstruction, document improvements in lung function after the administration of medications, and to follow the progression or worsening of obstructive lung disease. The 2 most important measurements in spirometry and OLD are FEV1 and FVC and their ratio. If FEV1 to FVC is greater than 75% of predicted, it is considered normal. With OLDs, this ratio will decrease as severity of lung obstruction increases. Other indicators of obstructive disease may be increased total lung capacities, TLCs, and increased residual volumes and functional residual capacities. Although obstructive diseases are the 3rd leading deadly disease, they are the 4th cause of death, right behind cardiovascular diseases, cancers, and accidents. The main preventable cause of COPD is cigarette smoking. Other causes, such as inhalation of certain chemicals, air pollution, and occupational dust may also play a role. Genetics, in the form of alpha-1 antitrypsin deficiency, affects surfactant production and integrity of the alveolar sac, leading to early onset emphysema, and should be considered in all patients exhibiting COPD in their 30s and 40s. Emphysema is a condition characterized by alveolar destruction and enlargement of air spaces distal to the terminal bronchioles, including the alveolar ducts and alveoli. And although recent studies have shown the lung's ability to repair itself, emphysema represents the balance between destruction and repair, particularly when genetic factors are involved. There are 3 subtypes of emphysema: centrilobular, which manifests as proximal dilation of the respiratory bronchioles, with alveolar ducts and sacs remaining normal; panlobular, where dilation of the air spaces occurs in the sinus and most frequently in the lung basis; and 3, distal esinor, where dilation occurs in air spaces underneath the apical pleura and is associated with apical bullae development and subsequent pneumothorax. Panlobular emphysema is the most common form associated with alpha-1 antitrypsin deficiency. All types are mostly caused by cigarette smoking, which causes inflammatory cell recruitment, proteolytic injury to the extracellular matrix, and cell death. Chronic bronchitis is defined as the presence of chronic productive cough for 3 months and 2 successive years. This hypersecretion of mucus begins in the large airways and moves to the smaller airways as the disease progresses, and hypertrophy of the submucosal glands also occurs and is measured with Reed index, which is gland to bronchial wall thickness ratio. The degree of small airway involvement determines the degree of disability. As with emphysema, cigarette smoking is the most common risk factor, although again, air pollution, particularly in other countries, and burning of wood and other biomass fuels are also risk factors. These factors cause chronic inflammation leading to destruction of the lung parenchyma, respiratory bronchioles, and alveoli. all leading to decreased lung recoil, elastance, and increased compliance. The gold standard for diagnosing COPD is again PFTs, with the FEV1 to FVC ratio as a definitive test as previously discussed. Classification of COPD severity ranges from 1 mild to 4 very severe. For the classification to be considered mild, FEV1 will be greater than 80% of predicted, FEV1 to FVC less than 70% of predicted, with symptoms of chronic cough with or without sputum production. Stage 2, which is moderate disease, will show FEV1 between 50 to 80% of predicted, FEV1 to FVC less than 70% of predicted, and the symptoms of cough with or without sputum and dyspnea. Stage 3, or severe, is seen by FEV1 between 30 to 50% of predicted, FEV1 to FVC less than 70%, and symptoms similar to Stage 2. Lastly, Stage 4, very severe, is characterized by FEV1 less than 30%, FEV1 to FVC less than 70% of predicted, and symptoms of chronic cough with or without sputum, dyspnea, respiratory or right heart failure, and weight loss. In addition to PFTs and chest x-rays, the physical exam may reveal a prolonged expiratory phase beyond 4 seconds, and wheezing, rhonchi, or diminished breath sounds on auscultation. Percussion will often reveal hyperresonance due to hyperinflation, and patients may exhibit signs of respiratory distress such as tachypnea and accessory muscle use. Pursed lip breathing and tripoding are also compensatory mechanisms seen with these patients. Cyanosis and decreased SpO2s will often be present. Medical management includes smoking cessation, pharmacotherapy such as bronchodilators and corticosteroids, influenza and pneumococcal vaccines to prevent COPD exacerbations related to infection, treatment of underlying sleep disorders such as sleep apnea, and pulmonary rehabilitation and exercise training to prevent muscle wasting and improve anxiety and depression symptoms. Surgical excision of bullae, or lung volume reduction surgery, LVRS, may help to improve lung mechanics and function of the respiratory muscles by reducing lung hyperinflation, but is only used in carefully selected patients. The most important recommendation for all COPD patients is smoking cessation, as it can prevent the onset and progression of COPD.